and welcome to this special ACR review podcast brought to you by the IMID Forum. My name is Sofia Ramiro, and I'm a consultant rheumatologist and senior researcher at Leiden University Medical Center in the Netherlands. I'm joined today by Janet Pope, Professor of Medicine in the Division of Rheumatology at University of Western Ontario School of Medicine, and Professor Atul Deodhar, Professor and Medical Director at Oregon Health and Science University. Welcome, both of you.
Sofia.
Yes, and welcome.
Good. Yes, thank you both. In this podcast, we want to discuss with both of you what we all found most interesting at this year's ACR. There's a lot of RA, PSA, and axSpA content. The most important we captured in our highlights brochures, and there were over 50 abstracts across the conference that we have identified, which cover a wide range of key topics and therapeutics. And as always, if you would like to be informed about the key abstracts for lupus and scleroderma, you can access the highlights brochures and the preview podcasts for these disease areas over on the Lupus Forum and the Scleroderma Forum, respectively. So now we will start with RA. So Janet, over to you, please.
Great. Thank you so much. So there's so many abstracts to choose from. So I'm going to cover some, and some of them are examples, say, of efficacy, of real-world effectiveness, or safety. And so most of them are RA. Sometimes it's RA and PSA. So the first abstract was number 1676. And it was the Select Compare long-term study. So we know that that was an RCT of UPA versus adalimumab and methotrexate IR added to methotrexate. And these are the 7-year data. So the first thing is we already know that UPA was superior to adalimumab back at year 1 and year 2. And some patients could cross over and did okay crossing over back when these data were presented a long time ago. The other thing to note is that this is a giant study. It's over 1,600 patients randomized, and they're looking at year 7, so about half have dropped out by then. However, what's really important is 2 things. No new safety signals. So we know that zoster would be more elevated. Transaminase is a little bit, but not clinically relevant in general. And CK more elevated, all with UPA. Again, CK not clinically relevant. So serious infections, MACE, et cetera, were the same in both groups. Of course, it's difficult to know long-term superiority when you actually have half the people dropping out. But this was a safety analysis at 7 years. So nothing new, looking pretty darn equivalent other than the exceptions I said. Moving on, another example of safety, this was abstract 1359, and it was comparative safety of TOFA versus UPA and patients with RA. So first of all, even when you propensity score match, there could be confounding by indication, and UPA in the USA, where this came from, was out far more years after TOFA. So there might be differences, of course. So there were 6,000 RA patients or plus change, and they were matched with propensity score matching between UPA and TOFA. So it was a safety abstract. So they looked at various MACE events, and whether it's hard to know because it's not randomized, but TOFA did have more problems such as 2.5 times acute MI approximately, more strokes, more VTE, more diverticular disease, more pneumonia. Hyperlipidemia was increased a little bit, depression increased a little bit. So there were a lot of comparisons here. There was propensity score matching. The N is really large, but I honestly think that once warnings came by EMEA, FDA, and other authorities, there could have been prescriptions that were different, and there could have been moving away in the higher risk patients. So until there's a head-to-head, which frankly there never will be. TOFA's been generic in Canada and is becoming generic in many other countries over the near future. No one's going to do a head-to-head. Will this change my practice? No, I don't think so. Let's move on to something else. What about maintaining a target? So this was abstract I think it is 1349, and it's looking at remission in a study called the Uphold study. First author, Andrew Oster, out of the Australian area. So Uphold was an observational study on UPA-naive RA patients, and they collected patients over 4 years from October 2020 to May 2024. And they wanted to look at remission with an okay definition of remission, less than 2.6 DAS CRP remission at 6 months, and then maintenance of remission at 12 months. So what they found was basically a large study. So almost 1,700 patients received one or more tablets of UPA, and it was monotherapy in almost half, CSD MARDs, of course, in the other half. Of these patients, almost 1,700, about 1,000 or 60% completed 2 years. But the primary outcome was at 6 months. So I think this is actually really nice to see in the real world, because remission was actually very high. Many patients were prior BD-MARD exposed. I think about 65% almost, and almost 20% were TSD-MARD previously exposed, but of course not UPA. So what did they find? They basically found that DAS remission at 6 months was really high. It was almost, I'm forgetting the percent now. It was maintained by about 80% by 12 months. Non-responder imputation was greater than 60% had remission. But I think the overall rate was far higher than 70% at 6 months and then maintained. I might be a little bit low on that amount, but it was something like that. So this is important for my practice, because BD-MARD exposed and lots of them TSD-MARD exposed. I have switched TSD-MARD sometimes instead of going out of class due to patient preference of oral, or perhaps intolerability of the first where they might tolerate the second, or because I've run out of options. So this informs my practice. I really kind of like this one. Again, good to see no comparison group. What about safety again? So this was an infection one. So 0490, infections associated with monotherapy in looking at BD-MARDs and targeted synthetic DMARDs, a systematic review. This one I picked because it actually had 55,000 and change patients, and it was a systematic review of 127 RCTs. So I picked it, but unfortunately, it's not going to inform my practice. There's a lot of, it's a network meta-analysis, and for any individual patient, there is no take-home message. We have to look at the group means. We have to look at in the individual trials, what was their risk. You're often higher risk in BD-MARD IR using the next product than if you're methotrexate IR. And obviously the lowest risk of infection and side effects are methotrexate naive, but we don't have those indications. So I can't say too much more about that one, unfortunately. So you can see there's a variety of JAK abstracts and other BD-MARD abstracts in rheumatoid arthritis that might inform practice, and some of them might be generalizable to my patients. And in the end, I think we have to treat to a target, pick an option for our patients. If it doesn't work out, ensure there's adherence, modify the background therapy, or move on. So with that, I think there was many things that enhance what I already do for my patients in a real world treatment kind of scenario.
Thank you very much, Janet. Very useful. And then I think that selection was not random at all. I think you had good reasons for which you selected this abstract. And I think I understand you, and you will understand it better when I discuss the axSpA abstracts. Now let's first continue to PSA and to give the word to Atul, please.
Yeah, thank you, Sofia. So there were a lot of PSA abstracts in this big meeting, and I have chosen 5. It's difficult to choose, pick and choose. I chose 5 abstracts based on, will that help me in practice? Will that change my practice, or at least help me in my clinical practice? And the second thing is looking into the future, glimpse of what new drugs are coming. And those were 2 of my criteria. So the first one I want to discuss is abstract number 1454, long-term safety and tolerability of bimekizumab treatment across phase 2B and phase 3 studies in patients with axial spondyloarthritis or psoriatic arthritis. 3-year update from phase 3 studies. So this was a poster presented by Philip Meese, and the reason I chose this is bimekizumab is now established as a drug in almost all the countries around the world, IL-17A and IL-17F inhibitor. People still have questions about the safety of this drug because it's comparatively new. And always this kind of thing is in people's mind, whether IL-17F inhibition, in addition to IL-17A inhibitor, will that increase the toxicity? So here, this is a data cut from September of 2024 for axSpA and August of 2024 for psoriatic arthritis. They have, the company has published safety analysis with every study that they have done. But this was taken into account, all the studies that they did, phase 2B as well as phase 3 studies for axSpA as well as psoriatic arthritis. The total safety pool included 848 patients with psoriatic arthritis, 848 patients with axSpA and 1,400 patients with psoriatic arthritis. And they pooled this and looked at the entire data set combined with these two indications. The three most common treatment associated adverse events were, as expected, coronavirus infection, because these studies were done during the COVID pandemic, nasopharyngitis and upper respiratory tract infection, which is not surprising. What is important in daily practice is when you counsel the patient, you need to tell them some numbers. What is the risk of serious infection, which is admission to the hospital or requiring IV antibiotics? And that was quite low. The exposure-adjusted incidence rate is 1.4 for axSpA, 1.2 for psoriatic arthritis. Fungal infection, these are topics of special interest, and that was 8.1 for axSpA, 7.1. However, these fungal infections were mucocutaneous, mild to moderate in severity, and most of these were oral candidiasis. So if you separate oral candidiasis, it's about 4 per 100 patient years. How many people discontinued because of oral candidiasis? And that is very infrequent. In axSpA, it is 0.2 per 100 patient years. Psoriatic arthritis is 0.3. No systemic fungal infections at all. No active tuberculosis, no histoplasmosis, no coccidiomycosis, no blastoma. I mean, so these are the bad fungal infections. Those were not really seen. I think these things are important when we are, oh yes, and IBD, that was 0.7 and 0.2, 0.7 for axial SPA and 0.2 for psoriatic arthritis. These numbers are important to me when I'm counseling my patients, and I tell them that if I treat 100 patients like you for the next 1 year, less than one would have IBD. That they understand rather than per 100 patient years. And these are just one sentences you can use in your daily busy clinical practice, but those are sufficient to sort of counsel the patient. The second abstract is abstract number 0567, sonelokimab in biologic experienced patients with active PSA, results from ARGO, which is the phase 2 trial, and study designed for phase 3 trial, IZAR-2. Now, sonelokimab is a novel nanobody, not yet available to treat anywhere, but that binds both IL-17A and IL-17F with similar high affinity. And already ARGO study was presented before it demonstrated robust joint and skin response with sonelokimab in psoriatic arthritis. This particular poster was reporting the data specifically in patients with psoriatic arthritis with prior biologic exposure from the ARGO trial. And since the ARGO trial was small, it was phase 2 trial, they are designing phase 3 trial, specifically IZAR-2, that's the name of the trial, in patients with active psoriatic arthritis after prior biologic TNF inhibitor therapy. So this poster included data from what was previously presented, but specifically looking at biologic exposed PSA patient, and based on that, how they are going to have a phase 3 study. And suffice to say that the ARGO study showed interestingly, the response of patients with psoriatic arthritis patients who are exposed to biologic DMARDs was quite similar to patients who were biologic DMARD naive. And this is exciting. There's something similar was shown with bimekizumab, another IL-17A and F antibody, and sonelokimab is showing something similar, that the week 24 outcomes treated with this prior biologic DMARD was quite similar compared to patients who did not have exposure, such exposure. About 53% and patients actually had this prior exposure, by the way, in that study. Based on that, they have now planned an ACR-2 study. This is also the study which was the first one, Argo study. Based on that, they chose 2 dosages of sonelokimab. One is 60 milligram with load and 120 milligram with load. What they are going to do in phase 3 study is they are going to add another arm of risankizumab as a comparative arm, just to be looking at whether this drug is going to be better or not. Now, this study is ongoing, actively recruiting. This is the ACR-2 study, and we will soon find out the results probably in the next ACR. Abstract number 3 is an important one. Again, it kind of tells me, informs my patients when I'm counseling them. This is inhibition of structural damage progression with guselkumab, a selective IL-23 inhibitor in patients with active psoriatic arthritis. Results through week 24 of phase 3B study, a randomized double-blind placebo-controlled APEX study. This is abstract number 2368. So guselkumab they had done Discover-1 and Discover-2, 2 studies, and Discover-2 study, they did find that guselkumab was able to inhibit or reduce structural damage progression in patients with psoriatic arthritis. However, that was only in Q4 week dosages, 100 milligram Q4 week. 100 milligram Q8 week just missed the statistical endpoint. The p-value was not statistically significant, which was somewhat surprising. And then when they looked back, there were just 2 or 3 patients which kind of made the big difference. So they decided to do entirely new study called APEX. And this APEX study, this enrolled biologic naive adults with active psoriatic arthritis, 3 tender joint and 3 swollen joint. And these patients were primed to develop new erosions. So they had C-reactive protein of more than 0.3 milligram per deciliter. And they had to have more than 2 or more joints with erosions, baseline erosions on radiographs of hands and feet. And those patients were enrolled. Patients were randomized to receive guselkumab 100 milligram Q4 weeks, 100 milligram Q8 weeks. That was after the baseline week 4 and then every 8 weeks, and placebo. And the primary and secondary endpoints were ACR 20 response, as well as mean change from baseline in the psoriatic arthritis modified Van der Heide Sharp score. 2 readers were blinded in chronological order, and they did a pretty good job with all this. Results showed that now, with large number of patients, properly done study, properly divided, these baseline characteristics were balanced on both sides. They took care for that. Mean age was 53 years of this patient, and both dosages of guselkumab, Q4 weeks or Q8 weeks, 100 milligram dose, were statistically significantly better than placebo in reducing significant less radiographic progression, very small radiographic progression, I should say. The modified Van der Heide Sharp score for psoriatic arthritis was 0.55 and 0.54 versus 1.35 for placebo. So the ACR 20 response was statistically significantly better than placebo. That was not a surprise, that we knew already. So I think this is going to help me when I'm starting somebody on guselkumab, a patient in my clinical practice. I can tell them that this drug not only helps with signs and symptoms, however, helps in reducing radiographic progression. I must say, I struggle. I have had discussions with other colleagues about how exactly would IL-23 inhibitor reduce radiographic progression, and beyond that, it ultimately leads to IL-17 secretion through cells, which Th17 cells, and IL-17 has direct effect on osteoblast and osteoclast. I don't know that there is evidence that IL-23 itself has a direct effect on osteoclast. Be as it may, abstract number 0874, this is deucravacitinib on disease activity with psoriatic arthritis. This was a combined phase 3 psoriatic arthritis study. And the only reason I chose this was because deucravacitinib is a new molecule. People are now learning about this TYK2 inhibitors. Deucravacitinib is one, zasocitinib was another one. They had their posters and oral presentations at this ACR meeting. So here they report the deucravacitinib efficacy based on composite measures of disease activity. This study has already, there are two studies, POETIC-1, POETIC PSA-1 and POETIC PSA-2. They have already reported disease activity and response across several disease domains in comprehensive assessment. But here they looked at specifically composite measures, and they chose minimal disease activity, DAPSA, disease activity in psoriatic arthritis, PASDAS, psoriatic arthritis disease activity score, modified composite psoriatic disease activity index, this is modified CPDI, and PSARC, which is the psoriatic arthritis response criteria. Not many of us do these composite measures in daily practice. Most of us look at MDA, some of us do DAPSA. The PASDAS, modified CPDI, PSARC, etc. These are mostly research-related outcome measures. However, they wanted to look at this and compare this with placebo. And at week 16, there was a significantly higher proportion of patients treated with deucravacitinib versus placebo had all these composite measures of responses. So MDA response, DAPSA response, PSARC response, modified CPDI, they were all significantly better and greater in patients. So it was not surprising. The only reason to choose this was to bring in TYK2 inhibitor in our discussion today, since we all will be using this drug, which seems to be pretty safe. One more thing this particular abstract showed was the efficacy was consistently higher and pretty similar in male and female patients. There were several abstracts looking at male versus female and trying to explore why the responses may be better in male. This particular drug seems to be working equally well in both sexes. The last abstract I'm going to discuss is abstract number 0559. This is impact of secukinumab on cardiovascular disease in patients with psoriasis, PSA, axSpA, systematic review of existing evidence. So this is a systematic review. And this is important because TNF inhibitors are a mature class of drugs. And in large nationwide databases from Europe, people have shown that patients with rheumatoid arthritis and even psoriatic arthritis who were on TNF inhibitors have a reduced risk of serious myocardial MACE events and even dying. Secukinumab, of course, IL-17 inhibitors came later, and we are all eager to know whether IL-17 inhibitor as a class would be similar to TNF inhibitors by controlling the inflammation. Are they going to reduce cardiovascular disease, which is a hot topic in the field of spondyloarthritis? This is systematic review about the existing evidence, and they combined psoriasis, psoriatic arthritis, axSpA. A large number of, they found 198 articles. Out of that, 46 were eligible for inclusion, 9 were meta-analysis, 13 were randomized control trial, 11 retrospective analysis, 9 prospective studies, etc. Some were observational studies. The bottom line is they couldn't really find evidence for death as the major outcome. However, they found that secukinumab was not associated with increased MACE. Whether it was reduced, they couldn't really say. There were improvements, though, in systemic inflammatory markers, C-reactive protein, neutrophil to lymphocyte ratio, markers of oxidative stress, etc. And so indirectly, they are saying that some studies reported also favorable impact. There were a few studies looking at Doppler on the carotid arteries about the vascular health. So indirectly, we can say that secukinumab might be improving endothelial function, reduced arterial stiffness, coronary flows, etc., etc. So in short, conclusion was secukinumab was associated with a reduction in systemic inflammation and oxidative stress. These are not direct, these are surrogate markers for cardiovascular mortality. But this also helps in our journey to treat the patient as a whole and not just treat their disease, but also take a step back and look at their overall risk that they have because of this chronic inflammatory disease. Thank you.
Thank you very much, Atul. We have gone a bit over time, but I didn't want to interrupt you. But the good thing is that you have selected 2 abstracts that included PSA and axSpA, and they were part of my selection. So we can have my selection on axSpA a little bit shorter. And continuing on selection made by Janet in the beginning, and I alluded to it when I was commenting on it, I think we tend to select studies that somehow have comparison of available treatments, because selecting which is the best treatment for our patients remains a hot topic in our daily clinical practice, and especially in axSpA, because in RA you have a luxury position. But I would say that in axSpA, in the absence of head-to-head trials, then observational studies keep trying to address this question. So the first abstract I would like to comment on is 1444 by Jeff Curtis and colleagues, where they have compared real-world effectiveness of tofacitinib, TNF inhibitors, and IL-17 inhibitors in axSpA, and they have used the claims data set from the US. They have included a total of more than 800 patients on tofacitinib, more than 14,000 patients on TNF inhibitors, and more than 4,000 on IL-17 inhibitors. And prior to propensity score weighting, there were differences between the drug classes. And if we compare the group of tofacitinib compared to TNF inhibitor or IL-17 inhibitor, so the group of tofa used more glucocorticoids, more opioids, more non-opioid pain medication, and more CS-DMARD at baseline. But then they adjusted the analysis for propensity score, as Janet mentioned. It's not the holy grail, but it's much better than not doing it. At least there is some attempt to adjusting for confounding by indication, which is inherent when we treat patients in our daily clinical practice, and patients are not randomly allocated to these treatments when we are comparing them. So after propensity scoring weighting, the three drug classes showed comparable effectiveness. And with effectiveness, they have used 8 criteria to define it, being defined as high adherence to the treatment, above 80%, no switching to another advanced treatment, no dose escalation, no addition of a conventional synthetic DMARD or glucocorticoids, not more than 1 glucocorticoid injection in the past 90 days, no new pain medication or no spinal procedure. Considering this composite endpoint as they assessed, they found an efficacy of 28% for tofacitinib, 32% for TNF inhibitor, and 28% for IL-17 inhibitor. So no big differences. Also in terms of survival of treatment, so treatment discontinuation, there were no differences between the drug classes. So in conclusion, using real-world data, patients with axSpA who initiated tofacitinib, TNF inhibitors, or IL-17 inhibitors had similar effectiveness within the first 6 months of treatment initiation. And if we continue on treatment comparisons, because as I mentioned, this for us a hot topic and a need in our daily clinical practice, José Miguel Senabre and colleagues from Spain have presented abstract 1446, in which they have investigated the best strategy after failure of a first TNF inhibitor, whether it would be better to cycle to another TNF inhibitor or swapping to a different mode of action. They have used data from their nationwide registry, the BioBadazer, and they analyzed the survival of the treatment, so the second advanced treatment that was started, the biological or targeted synthetic DMARD. Analyses were adjusted for potential confounders, but no propensity score was used to balance the confounders or to try to adjust for confounding by indication. In total, 827 patients with axSpA were included. 73% continued on a TNF inhibitor, so cycling, and 27% switched to another mode of action, so swapping, of which 91% to an IL-17 inhibitor. So we're actually looking mainly at the comparison between TNF inhibitor and IL-17 inhibitor in those that are insufficient responders to TNF inhibitors. And at baseline, in the swapping cohort, there was a higher proportion of patients that had initiated their second-line treatment after 2020. So it was 60% compared to 45% in the cyclic cohort. This is as expected, because in more recent years, we have more options allowing rheumatologists to be more proactive with swapping than what we were before, because we could mainly only have TNF inhibitors. And then when we look at treatment discontinuation of these two treatment strategies, swapping was associated with a higher hazard for treatment discontinuation, with a higher hazard ratio of 1.5, statistically significant. However, although this analysis was adjusted for start of treatment after 2020, that I mentioned to you was a baseline difference between the groups, this disbalance between the cohorts raises suspicion of confounding by indication. So interesting findings, but I think we need to interpret them with caution in light of potential confounding by indication. And this is what always makes it so challenging to have head-to-head comparisons, though they are so valuable, and we want so much to learn from them. Now, moving to another topic, I wanted to move to bimekizumab, and Atul already was so kind to present the first abstract that I had selected on safety over 3 years in PSA and axSpA. And then continuing on another abstract on bimekizumab, Fabian Proft and colleagues presented abstract 2347, in which they assessed the maintenance of response to bimekizumab over 3 years in patients who had achieved a response at 16 weeks. This was done in both BMobile trials, so in both radiographic axSpA and non-radiographic axSpA. And so the starting point were the patients that had responded at week 16. If we start with ASAS40, those were 160 patients, which corresponds to 46% of the patients initially included in the trial with non-responder imputation. And 80% of those still achieved ASAS40 at week 164, meaning that they maintained their response. In trials, we use mainly ASAS40, but in daily clinical practice, an ASAS below 2.1 is a much more relevant measure. If we translate it to ASAS below 2.1, of 152 patients that had achieved an ASAS below 2.1 at week 16, so that's 44% of the patients, again, non-responder imputation, the patients included in the trial, after 164 weeks, 79% were still in ASAS below 2.1. So in conclusion, a high proportion of bimekizumab randomized patients who achieved stringent clinical responses at week 16 maintained those to week 164 across the full spectrum of axSpA, and half of the patients that achieved ASAS below 2.1 at week 16 never lost their response in every single visit up to week 164. This is also data. It's encouraging and reassuring to see this new data for bimekizumab aligned with data that we have seen for other drugs, that actually an early response really predicts long outcomes in our patients. Moving to another topic, non-nociceptive pain, a very important topic that I think we all recognize in our daily clinical practice. Podubny and colleagues presented abstract 1435. It's a post-hoc analysis of a real-world study in patients with axSpA, and they have examined the impact of upadacitinib on non-nociceptive pain and the association of non-nociceptive pain with residual symptoms like sleep disturbance, anxiety, and depression. I think all recognizable to all of us. UPSTAND was the name of the study, was a 12-month multi-country, non-interventional, observational study in evaluating the effectiveness of upadacitinib on pain in adults with axSpA. Patients were grouped according to their pain for this analysis. So neuropathic pain, the severity of neuropathic pain was captured by the pain detect, and then 3 classes were made based on the intensity of the pain. And also based on the severity of nociplastic pain, which was captured with a widespread pain index. Again, 3 categories were made according to the intensity or the severity of nociplastic pain. And also what they did, they combined a widespread pain index with a symptom severity score to assess the presence of nociplastic pain fulfilling fibromyalgia criteria, classification criteria, as per Fred Wolf. Then they analyzed clinical outcomes such as ASAS, back pain, fatigue, sleep quality, anxiety, and depression in each of the subgroups according to the pain intensity and severity. And what they saw is that the proportion of patients in the least severe pain groups increased from baseline over time, and the opposite, that the proportion of patients in the severe pain groups or meeting criteria for fibromyalgia decreased over time. So what the authors conclude is that in patients with axSpA, treatment with upadacitinib is associated with improvements in non-nociceptive pain, and that non-nociceptive pain is associated with residual symptoms, sleep disturbance, anxiety, depression, and fatigue. I think this is interesting and important data. On the one hand, very good to see this data, and it can very well be very true. On the other hand, I think we can't really, with certainty, assign improvements seen by upadacitinib to non-nociceptive pain. They can still be related with improvement in the inflammatory activity of the disease. And it's true that we know that JAK inhibitors seem to be more promising in terms of pain control beyond their effects on the inflammatory activity. But I think we have to be cautious with the generalization that we should not consider that such drugs are efficacious in case of non-nociceptive pain in the absence of inflammatory activity. And I was moving to another abstract that Atul was also so kind to already summarize for us on the effect of secukinumab on cardiovascular effects. So I want to have a last word on the abstract 0854 from Maksimovic and colleagues, from which Atul and I are also co-authors, presented at the plenary session, presenting the ACR and axSpA classification criteria. This has been a project of many years, followed a thorough assessment, and now we have updated classification criteria that are relatively similar on the one hand to the existing ACR classification criteria, but they provide a more specific set of criteria. So we have achieved higher specificity as we wanted, of 90% with a sensitivity of 80%. And I think the most important novelty is that the MRI indicative of axSpA can cover not only inflammatory lesions, but also structural lesions like erosions, fat lesions in an overall assessment by the reader. And imaging, HLA-B27 and inflammatory back pain are the spondyloarthritis features that are scoring highest to allow the classification of axSpA. So I think this is are the highlights that I wanted to bring on axSpA. I think we have had quite a good session covering several abstracts. I don't know whether Janet and Atul, you would like to add anything, any comment on this abstracts we've presented, or anything else we have thought should still be safe today? Yes, please, Janet.
So I think what's really important is there were a lot of studies that were head-to-head, some of which were certainly highlighted. It never tells us within an individual what to do. It'll tell us on a group means that maybe after TNF, say in axSpA, you can go to another TNF, or you can go to a different BDMARD or a different class and do quite okay on each. Within an individual, who knows? And I think we do try to have personalized medicine, and maybe someday we'll get it. That's one thing. The second thing is, even when there are head-to-head, so there was a head-to-head, a couple of things presented after, say, BDMARD-IR and RA as a for instance. The head-to-heads still don't always inform guidelines, and I think part of it is because it'll depend on access, individual conversation with the patient on risk, benefit, patient preference, physician preference for sure. And so our guidelines are often very broad because within the next individual I'm going to treat, there at this point in time is no right answer. And I think someday we'll have more personalized medicine where, as for instance, in breast cancer, depending on the stage and all the factors of receptors and markers, you kind of know within a group means what to do. I don't think we're there yet.
Thank you. Very useful addition, and indeed very much in line with several of the abstracts that we have presented today, because we all find them relevant. So I think this has been a very productive discussion, and I think it's time to close this podcast. I hope you have enjoyed this review podcast. Don't forget to visit the IMID forum, that's imidforum.com. There you will find a range of great RA, PSA, axSpA, dermatology and gastroenterology content, including detailed slide decks of the top research, monthly podcasts, and even special webinars around key topics of interest. Thank you as always, and best of luck in your clinical practice.